Fantastic. Right, I'm delighted to introduce you to our second guest, Professor Vaughan Keeley. No, Denise, you're the headline act. So, you know, now, as we know, dinner is at 6. So what might happen is that the starter will be delivered to you while Vaughan is speaking. So if that's okay. But Professor Vaughan Keeley, an honorary professor at the University of Nottingham, and medical school, and a consultant physician specialising in lymphedema. He leads the lymphedema service in Derby, Nottingham, and Mansfield in the East Midlands. And the service treats all types of lymphedema, chronic edema in adults and children. On that basis, cue Liv Lavender, who joins us this evening. Thank you for joining us, Liv and Mum Tasha. And in 2020, the service was designated as Comprehensive Centre of Excellence for Lymphatic Diseases by LEARN, the Lymphatic Education and Research Network in the US. So if you could put your hands together for a warm welcome to Professor Vaughan Keeley.
Thank you very much, Matt, for that wonderful introduction. As Chris has already said, those of us of a certain age were a bit scared to not have slides. And so I've got my bit of paper as well, just to guide me through. I've also been given the scary topic of cellulitis. And as Chris has already pointed out, I've learned fairly rapidly over the years that cellulitis is something that people with lymphedema are pretty scared of because it can be very scary. So I hope to guide you through some of the current sort of thinking, what we're trying to do to make cellulitis less scary, I hope, but also it is a significant and serious problem. So hopefully this will be useful. So first thing is to say what cellulitis is. You probably all know this anyway, but it's something that's very common in lymphedema. Chris has already mentioned the 37% in children in the study that she's carried out. Interestingly, and another study that we did as part of Lymprint, it was around the same sort of number in adults as well, of people who had lymphedema who had experienced at least one episode of cellulitis. And another group in France did a similar thing, and they got the same sort of number. So I'm sure it's not exactly 37%, but it's a useful figure. And the other bit about it is that it's something that you can get more than once. And again, the study in France showed that about a quarter of people with lymphedema will experience recurrent episodes of cellulitis. So within a common condition, it's a common problem, so it is of significance. It's also something that we know can cause damage to the lymph system and make the lymphedema worse. So the more times you get cellulitis, the lymphedema is likely to get worse. And unfortunately, it works the other way around. If your lymphedema is worse, you're more likely to get cellulitis. So there's a bit of a vicious circle in there that we're all trying to stop happening. What is it? It's an infection. It's a bacterial infection. It's not a viral infection. It's caused by bacteria. Still a bit of debate about which bacteria, but generally we will feel that streptococcal bacteria are the particular culprits in most situations. It can be a relatively mild condition, but can also be very serious and lead to sepsis. And unfortunately, there is a mortality, small, fortunately, but it's important that we recognise it early and get it treated early to improve the outcomes. What does it feel like to get cellulitis? There's a bit of debate about whether cellulitis is different in lymphedema from other conditions, and we're not entirely clear about that. But what is quite striking is that people with lymphedema often feel ill in themselves before they notice any difference in their lymphodematous area, be it the arm, leg, or anywhere else in the body. You can get cellulitis anywhere, but you often feel ill when you're getting cellulitis with flu-like symptoms, fever, shivery, aching, before you notice that there's any redness or swelling. And those of you who've had more than one episode, it's quite common that you get the same sort of pattern each time, and it can be all sorts of strange things. Some patients say to me, oh, well, I get a pain in my groin area, and then a leg starts to hurt, and the ones say, well, get another particular symptom. I know when I'm going to cellulitis, I feel a particular way. Other people, it can change each time, so it's not particularly reliable, that. But it's an important topic because that, when you've got the cellulitis, your limb, or let's say, for argument's sake, we'll talk about the limb to begin with, it starts to become red, inflamed, more swollen and painful. And those are the sort of typical features of it. Quite often, it's a very clear demarcated redness. You can almost draw a line around it, and people often do to make sure that it's getting better from when you started your treatment. But sometimes it's a funny blotchy rash and it doesn't always look the same. There's no great test we've got to say this is cellulitis. You can do cultures of this, but it doesn't, they often don't show things. We can do blood tests which don't necessarily prove it. So it's a difficult diagnosis to make, and there's no simple solution in saying, wait, we take this blood test, measure this, we've got an answer. And that's a challenge really, because not only is it not well known about, as Chris was hinting about earlier, but it's actually not an easy diagnosis to make. So we end up with a sort of spectrum of things, of people developing cellulitis with lymphedema, and they go to their GP or they go somewhere and they don't know about it and they can't make the diagnosis. And that's even more scary. And it was the experience of the LSN from their members some years ago, where they were getting loads and loads of people saying, I go to my GP and they don't know anything about this. That got me and a few other people, and I say this metaphorically, locked into a room by Anita Wallace, the chair of the LSN, and supported by Karen, to come up with some guidelines about how cellulitis and lymphedema should be managed. And that's something we did in 2005, was it, somewhere around then, Karen? And we've been doing it every year since, effectively. I say that we're not starting from scratch, but we did. It's what we call a consensus document. So unfortunately, as with many things in lymphedema, despite efforts of people like Chris and others, we've got very little research evidence about what we do. And so we talk about consensus guidelines because we've sat down, we looked at the literature, we looked at what we were doing, what seemed to work and what didn't seem to work, and we came up with these guidelines. And they've been renewed and revived on an annual basis ever since. We did a fairly major revision in 2022 because there had been some new evidence, which is really exciting. So we are getting some evidence now about how we should be treating these things. And so that's become a fairly standard document. And I think it has made a difference to how people are cared for. It's available to GPs and to other people in hospitals and things. So I think it's made a difference. So hopefully it will change. There are patient information leaflets as well to go with that. The LSN produces them and other clinics produce their own. So those are available. However, we do have the opposite side of the coin that particularly with leg lymphedema, you can get symptoms that look a bit like cellulitis. So the leg can go red and swollen and more painful, but it's not an infection. So we run the risk of people receiving antibiotics that they don't need. It's a problem, but it's actually caused by something else. It can be an inflammation in the veins, it can be a skin problem, all sorts of different things. So there's a need to get the diagnosis right, and that's something that we try and focus on, looking at the features that we've just been talking about. How do we treat it? Well, it's a bacterial infection, so it basically means using antibiotics to treat it. I'm not going to go into the details of that. The details, if you want to look them up, are available in that leaflet that's on the LSN website, for example, which you can access. But antibiotics are an important part of the management. Catching it early is important as well. So we normally say to people, it's not something you necessarily need to get treated in the middle of the night, but sometimes in people it progresses very quickly. So for some patients, and they tend to recognize this, who have significant problems, they know that they're going to get ill very quickly if they've had it before. So they need to get attention straight away, and they may need to go into hospital for intravenous antibiotics. But most people, it can be treated with antibiotics by mouth, which they can have at home. So one of the key bits that we've tried to change is how long the antibiotics are given for. There's a growing caution in the use of antibiotics, as you'll all be aware. And so we try to use antibiotics for as short a time as possible. But in cellulitis and lymphedema, that can cause problems. And we've recognized over the years that a short course of antibiotics, like 5 days or 7 days, which you may have for other things, may not be enough. You can get better, but cellulitis then may come back after a week or two. So we usually recommend a 2-week course. And that's something that still hasn't quite got universally accepted. And we see people who've had a week's worth, and then 2 weeks later they have another week's worth, and then 2 weeks after that have another week's worth. And they've got what seems to be a recurrent problem where it isn't. Actually, it's just one episode that's not being fully treated. So that's something that we're concerned about. So because it's a significant problem, how do we reduce the risk of getting it? So there are two aspects of that. There's, in the first place, if you've never had one, how do you stop yourself getting cellulitis? Well, we've learned now that actually treating the lymphedema is important. There's growing evidence that managing lymphedema in various ways, but the standard treatments with compression, the things you're all familiar with, and Denise will talk about, I'm sure, are important in managing the reducing your risk of getting cellulitis in the first place. And then we talk about things like skin care, which is always meticulous. That's the word we use with skin care, which means you have to be very careful with things. I think the whole point of skin care is the main use is the use of emollients, which are protecting the skin. They moisturize the skin and make sure the physical barrier to infection is there. But you're all aware that we talk about things like avoiding having injections. We avoid trying to avoid cuts and scratches in the area that has lymphedema. There's been some different thinking about that, because at one stage we were saying to women who had lymphedema of the arm after breast cancer, or don't get your blood pressure measured in that arm, and don't have a blood test taken from that arm. It's probably overcautious of that. There's some studies being done in the States which suggest we may be being overcautious. But unfortunately, I can understand this. Everybody thinks about, well, what made my lymphedema start? And oh, it was after I had that blood pressure taken, or it's after the injection. So I think we're still being maybe overcautious, but I think it's still reasonable. Certainly avoiding having drips in the arm and chemotherapy in the arm is sensible, because that can cause problems. What other things can we do to reduce the risk? Ideally, if people get things like athlete's foot or skin conditions, treating those is important, because any breaks in the skin make it easy for the bacteria to get in, so that those are important things to do. But there are other more general things that have emerged. In one of the lymphedema studies that Chris referred to earlier, we found that people's weight had an influence on their incidence of cellulitis. We've known for a while that diabetes makes you more prone to cellulitis, but this was just people's BMI, as we would measure it. Weight was an important factor. So people with a high BMI were more likely to get cellulitis. We haven't got the proof that reducing your BMI reduces the risk, but that seems logical. So we advise that as well. So I think there are things like that that are sensible to do. So managing the lymphedema, the surgical operations for treating lymphedema, which, as you know, are sort of in their infancy still, but some of the work that's coming out of that suggests that they reduce the risk of cellulitis as well. So there are all sorts of things that are encouraging. So despite all that, some people still keep getting cellulitis, and we then have to look at how we manage that. And we are very cautious about using antibiotics long term, and there's this thing that WHO has been pushing for the last few years, quite rightly, about antibiotic stewardship, so-called. So it's our careful use of antibiotics, so we reduce the risk of developing resistance in the bacteria, so that they no longer respond to the antibiotic treatments. So when we think about this, you've probably heard of antibiotic prophylaxis to stop you getting cellulitis, and we do use that, but we use it very carefully. So we think, first of all, does this person need it? First bit is, what do we mean by recurrent cellulitis? So we have a sort of rule of thumb that if you have 2 or more episodes of cellulitis in 1 year, that sort of triggers us to think, do we need to think about low-dose antibiotics to stop it happening? But equally, we have to think, actually, were these real episodes of cellulitis? Was it one of these conditions that makes the leg look red and inflamed, but not the bacterial infection? So we go through that process. Was it somebody had too short a course of antibiotics? So that sort of 3 episodes of cellulitis that was really one. How do we assess that? And I think we also think if there's something that we know has caused the cellulitis, just as an example, like an ingrowing toenail. Well, if you treat the ingrowing toenail, then naturally, do you need long-term low-dose antibiotics? Probably not. You can treat the problem that caused it and therefore avoid them. But there are some people that need long-term antibiotics for a period of time. I say a period of time because we try to not do them forever. So in this group of patients, we use penicillin is the most commonly used antibiotic, a low-dose penicillin. And that has now got evidence that that's effective, it works, and it seems to be very well tolerated. You don't seem to get lots of side effects from it. But as you know, loads of people are allergic to penicillin. once we go away from penicillin, all the decisions about this get more difficult because the other antibiotics are more difficult to use. The bugs can get resistant to them. They can cause more side effects. So we are very cautious if people are allergic to penicillin, to the point that we check whether they're really allergic to penicillin sometimes, and sometimes very rarely, but desensitize patients against make them able to take penicillin. It's a big, complicated process, but in principle, we prefer, if we can, to use penicillin, but there are other alternatives that we use, particularly doxycycline and the things like clarithromycin and such like. So there are other antibiotics that can be used. But the way we use them now is to start them for people that have got recurrent episodes of cellulitis, but try to do things that reduce those risk factors that I've talked about earlier. If we can do that, then hopefully we can stop the antibiotics prophylaxis, and they don't need them any longer because the risk has been reduced. And that's, we haven't actually got some numbers to share, but we see a lot of patients where we're able to do that in our clinic, and a few need to go back on them later, but there's quite a few that we can actually get off them. And then there's the other issue, which I think Matt particularly wanted me to talk about, which was the what we call the in-case course of antibiotics, or the rescue pack of antibiotics, which is having a course of antibiotics at home so you can start it quickly if you get cellulitis. I think GPs are sometimes cautious about giving that, and I can understand that. I think if you've never had cellulitis and you've got lymphedema, then it's not always easy to recognise it the first time, and I think you do need to see somebody to confirm the diagnosis and to give the appropriate treatment. As I usually say to patients, if it's at a weekend that it happens, don't wait till the Monday. We don't need to necessarily do it in the middle of the night, but get seen on a Saturday if it happens on a Saturday, or on a Sunday if it happens on a Sunday, because waiting to the Monday, you may end up in hospital because it's got more advanced. But there is a place for these rescue packs of antibiotics. And it's particularly for people who are known, like I said earlier, who've known to have had previous episodes, and they get used to the pattern, and they know just absolutely that they've got an episode, and then they have to go to their GP, and they may have a delay in getting antibiotics. And in that group, particularly if you're away somewhere and maybe not easy access to medical help, having a supply of, usually a 2-week supply of the antibiotics that you use to treat cellulitis is a very reasonable thing to do. So we recommend that. We usually ask GPs to prescribe that in appropriate patients as need be. So it's a thing that's important. But I think it's not something that you need, that everybody needs to have if they've not had cellulitis. I think it's something we need to be a bit more cautious about than that. And GPs don't usually prescribe it in those circumstances. So that, in a nutshell, is a quick guide to cellulitis in lymphedema. I think it's something that can be very scary, but if we take some of these precautions and people are more aware of it, and it's treated early, it can be a problem and a nuisance, but actually manageable. Thank you very much.
Thank you. Yeah, let's just stop this.
Okay.
Right. Thank you so much indeed for speaking. I hope you find that useful. A quick show of hands. How many of you have had lymphedema? How many of you had cellulitis in the room? That's a high number. I'll include myself in that. Is it the most painful thing you've ever experienced? Show of hands. Yeah. So the rescue pack, for those who've had it once and perhaps twice, is worth having in the cupboard, especially if you're abroad, right? And it happens when you're in the middle of nowhere. It's something that you can reach for. The rescue pack is featured on the website and in the book. Karen, I believe, has brought these alert cards. So anybody that has lymphedema on the tables there, you find these alert cards. Please have a read. Please carry these in your wallet and your purse, just in case, because it's self-explanatory. I won't go into detail, but please take one of these away with you. Now, do we have any questions for Professor Keeley before we have our dinner? Any questions from the floor? No? Well, you'll be here for a while, I guess. Will, yeah. So if you don't want to ask a question, you want to grab him at the bar. A non-alcoholic 0 beer is typical. Be on hand to ask your question. So thank you so much for coming.
Thank you for inviting me.
Thank you. And it's almost like we've planned this because what's the time? So we've got time, ladies and gents, to have a quick break, grab some drinks and come on back in for 6 o'clock when your starters will be hopefully ready for you. So thank you very much. Thank you.